All right. Yeah, I think we're on time now. So without further ado, welcome back, everyone. After a 3-week break this time, and thanks again for the presenters and the contributors for sending in their cases. I think we again have a complex set of cases today. So without further ado, I'll hand it over to the Ahmedabad group. If Diksha is there, she can take over. The chat is open. Please leave your comments and inputs for all the cases. Over to you, Diksha, if you're there.
Yes, sir.
Yeah.
Good evening, everyone. So here is the case of 11-year-old male child who presented with us with the difficulty in walking, required support to walk since last 2 months, associated with the tremors of the both hands, more with the action. So there was more of action tremors and difficulty in speech simultaneously over the last 2 months, which was increasing in the nature. Birth and development was normal. Outside has been diagnosed as a acute cerebellar ataxia and treated accordingly with the injection methylprednisolone, followed by the tapering dose of the steroids and tablet Inderal. There was a notice, they have been noticed that there was a mild or minimal improvement after taking this medication since last 1 month, but there was no any major improvement has been noticed. So this is the video of the child before the treatment. So when the symptoms have started, so you can see there is a significant ataxia while he is walking. And as you can see, as child is grabbing the steel glass, he is having the action tremors. And was not able to drink.
Okay, so I have imaging after this. You want me to go ahead with that?
Yes, sir.
Okay. So 2 months into illness, we have the first MRI scan. Is that right?
Yes, sir.
Okay. Yeah. Slight apologies for the pixelated images. We have only external films. So this is T2 axle sequences going from the bottom to top. I'm not sure if you can appreciate, but there is abnormalities in the supracerebral peduncle out there, the dorsal aspect of the pons, going up to the midbrain more confluently out there. And if you go more superiorly, you have involvement of the subthalamic nuclei, also the internal capsules, and some degree of involvement of the basal ganglia. Coming to the top, you can see some cortical atrophy demonstrated in the bilateral cerebral hemispheres, more along the superficial frontal and parietal lobes. Let's see if the changes can be better appreciated on the flares. So on the flares, again, you have hyperintensities in the brainstems, the cerebral peduncles, and also in the central structures of the supratemporal brain, that is the deep brain nuclear structures and the white matter structures. Out there, some involvement of the subinsular white matter also is demonstrated, and some symptoms of mobile posterior periventricular white matter changes are also seen. In terms of malformations, could not appreciate any malformations on these sequences. No focal lesions per se, and yeah, these were the main findings I could appreciate. On the SAT sequences, again, midline structures are formed, are normal, but if you can see again, there is involvement of the brainstem, especially the upper and mid brainstem structures demonstrating these hyperintense changes. On diffusion weight sequences, we don't have an ADC to see if T2 shines through a real diffusion, but you can appreciate there are symmetrical hyperintensities involving the corticospinal tracts, that is the posterior mutinal capsules, and also some degree of the peritrigonal posterior periventricular white matter demonstrating mild change of diffusion. High signal, don't have an ADC to correlate if there are true changes or not. Other than those findings and some abnormalities in the midbrain, these are the main findings on the diffusion weighted sequences. Then the child was given treatment as Dr. Prisha had mentioned, and yeah, this is after.
So this is the after treatment of injection methylprednisolone, and after 1 month we have already so child has been taken IVIG also. So in this video you can see the past waiting in the finger nose test. So child was having all the signs of the cerebellar. Scanning speech was there. This is the OPD video of the walking. You can see there is still a significant ataxia child was having. So there was no any improvement, major improvement or minimal improvement we can see after the methylprednisolone and IVIG also. So after that, we have this investigation was done outside. CSF routine micro was done. Total count was 2 with the protein 20.8 and sugar 62 with the RBC 10. And autoimmune encephalitis panel was negative. NMO MOG was negative. Vitamin B12 was negative. CSF electrophoresis was suggestive of the positive for the oligoclonal band, 2 band in the CSF and no band in the serum. And in May, after giving the IVIG, there was a further investigation done outside with the albumin 4.5, which was within the normal range, IgG again normal, and CSF albumin and IgG index was again normal, and AFP gram and India was negative. So question from my side and from my team was whether it was acute demyelinating disorder, or we can say for that acute cerebellar syndrome versus MS. And as the child was having only mild improvement after methylprednisolone and IVIG, which demyelinating condition will suggest this type of MRI pattern and will present like this?
These patterns are from literature or just our cases, findings of our case?
This photograph, sir?
Yeah.
Yes,
So,
sir.
so our child had present in CSF and absent in serum. Is that right?
Yes, sir. Yes, sir.
But this is not specific.
But,
I mean,
yeah, it can be seen in many conditions. Yeah, sorry again.
This OCP finding is not specific. For me, the overall situation reminds me of Bickerstaff brainstem encephalitis. This is unlikely MS, and this is unlikely a simple demyelinating condition. So this is somehow related to Miller-Fisher and other syndromes. Maybe you can check for the appropriate antibodies. I don't know the names offhand. Q1B and so on. And also the course can be protracted, and you should consider to escalate your treatment perhaps.
Okay, sir.
Yeah, I agree. The imaging doesn't fit MS, at least imaging wise.
Okay. And should we consider, sir, other demyelinating MS mimic in this picture?
I'm not sure which demyelinating fits in. And it is not as, if you see the intensity is not very bright, it's very hazy kind of intensity. Really demyelination should have been more bright, more focal in, maybe NMO can be seen, but I don't think it fits, clinically fits that pattern.
Okay.
And non-responsive to medication, that may be I'm not sure the duration, but.
And should we suspect, sir, Wilson or mitochondrial also?
Yeah, I was thinking Wilson, possible, but
this is not top on the list. I mean, you have an acute onset and you have a symmetrical condition and an MR which is, I think, the brainstem. This is not really mitochondrial and the superior cerebral peduncle. I mean, you can say mitochondrial to anything which is not known, but this is not on the top list.
Yeah, I agree. Mitochondrial, not the diffusion pattern also is not what we see in mitochondrial. I think for starters, maybe we should get a scan done or rescan done with a complete set of images, with also spinal imaging if possible. Then we can give a contrast and check. Since we have only a couple of sequences, it will be difficult, but at least it doesn't look like the classic demyelination what we see. And since 2 months and no improvement.
Yes, sir. And is there any role of MR spectroscopy in this type of case? Yeah, for that, we'll need to get the first complete set of conventional sequences. Based on that, if Dr. Vivek raised the SSP, I thought it's possible, but I'm not sure if myoclonus presence should be present or not. Maybe the clinicians can tell. Do you expect myoclonus by now for SSP in 2 months' time? Diksha? Yes, sir. Would you be expecting myoclonus? No myoclonus? No, sir. No, sir.
And
no myoclonus.
Was an EEG done, Dr. Vivek asked?
Yes, sir. EEG was done, but it was not suggestive of any HSP like pictures, and ceruloplasmin was also normal, sir, afterwards.
Okay. Yeah, so I think the chat we are at least agreeing that not typical demyelination to get a complete set of imaging, and then think for SSP raises the possibility. Those hazy kind of changes can be there because of encephalitis, another consideration.
Okay, sir.
Yeah. So we can just, the next steps would be get a follow-up scan, complete study. Maybe we'll also include the spine, at least the cervical spine with contrast. See if the changes are progressing or not. Usually the demyelination should not progress given the child has medication. So if it is progressing and there's more confluent changes, then we have to think of other possibilities than demyelination.
Sure, sir. I will get you to know.
Yeah.
Yes, sir.
Okay. All right. So yeah, I think let's see if anything also. Yeah, United MLD, Dr. Vivek, yeah, but the gray matter was more, brainstem and gray matter, brainstem, yes, but the brain nuclei, I thought maybe was slightly. Corticospinal tracts, yeah, they can be seen in juvenile form. All right. So Disha, yeah, your next step is rescan, and then maybe you can take it from there. Yeah.
Sure, sir. Thank you.
Yeah. Thank you. All right, Harika, what do you?
This is a 5-year, 8 months old boy born out of non-consanguineous marriage, first in birth order. He was
washroom. 13 per day. Yeah, go ahead, no problem.
He was 34 weaker, 1.5 kg, training lately after birth. History of NICU stay in view of prematurity. And he came to us with complaints of development delay, motor more than cognitive. But now he can walk independently. Ideal, he needs some help. And he had history of epileptic spasms in clusters since 9 months of age. And he was seizure free for almost 2 years and again had recurrence. Now he's having seizures like every day almost. On examination, head circumference is 46.5 centimeters with occipital plagiocephaly and extraocular movements are full with no nystagmus and good eye contact. Speech was also good. There is generalized hypotonia and DTS being 2 place and wide-based gait, and there is mild difficulty while turning and walking. And the thing is, he falls after taking 30 to 40 steps. But he gets up on his own and again he walks, but there is falls after taking 30 to 40 steps. So we evaluated as like global development delay with epileptic spasms and central hypotonia. So we have done imaging for this.
Yeah. So imaging, I think at 9 months of age, you can appreciate there is cerebral volume loss, predominantly in the frontal regions with changes for patchy hyperintensities involving the basal ganglia more along the caudate and the putamen out there. We have widened pericerebral spaces secondary to the atrophy. Also, if you can appreciate, the frontal horns are slightly more prominent given the reduction in the volume of the caudate nuclei. Yeah, so cerebral atrophy more along the frontal regions and also basal ganglia changes with some prominence of the frontal horns on the T2 axal sequences. No structural malformations, at least on these images. Yeah, coming to the flares, again, you can appreciate the tiny cystic changes in the basal ganglia, chronic changes what we have seen in the T2 various sequences, and also widened subarachnoid spaces. The estimated sequence, I think these are artifactual and not real calcifications or blooming foci. And T2 SAS sequence, you can appreciate there is some degree of volume loss in the corpus callosum. Also, again, you can appreciate the frontal predominant cerebral atrophy. So these are the only sequences I have. So the main findings to summarize is cerebral atrophy with the frontal dominance. Also basal ganglia changes, patchy changes, more chronic in nature given the volume loss and the cystic changes on the flare sequences. Don't have diffusion to see if there's any change of restricted diffusion out there or spectroscopy. If you concentrate on the basal ganglia abnormalities, these are the wide range of differentials going from inherited to acquired disorders. Yeah, the list is out here. These are typical examples what we see if we concentrate on the basal ganglia changes. But the child, again, additionally had epileptic spasms, cerebral atrophy. So whether the phenotypes match or not is to be looked at. This is again a diagnostic flowchart. If you concentrate on the basal ganglia changes, again, inherited and acquired forms. The common forms are as outlined out here. This child, suspecting a genetic disorder, underwent genetic analysis.
Yes, sir, like because perinatally also no significant history, and because this development delay and epileptic spasms, to know the etiology, we have done a metabolic workup also. Like ammonia was 393 and lactate was 19. It is borderline high, and because it is not fitting into this metabolic thing, we have done genetics also. It was showing compound heterozygous FRRS1L mutation, autosomal recessive. Mm, but the phenotype wise, it is fitting, but MRI wise, it is this basal ganglia changes that is not fitting into this. So, is there any other differentials or?
Yeah, so I checked the MRI patterns. The literature is very, I mean, there are only few case reports mentioned, and this was only um, uh, paper with imaging of the gene, and they had this child had cerebral atrophy, some degree of cerebral atrophy, and they mentioned that the chordates have reduced in volume. So I'm not sure what they're pointing out here. It's more on the ventricles. But yeah, these are the published cases. So in the clinical, I'm not sure if the clinical phenotype is matching the all. But this child did not have any dystonia, I think, which is common chorea dystonia.
He has no movement disorders, only seizures and this development delay with central hypotonia.
Okay. So among the published case reports, only 3 had imaging findings. So I'm not sure if to rely upon that or not. With that, I'll open the case if there are any other suggestions. Cerebral atrophy, and they mentioned flattening of caudate heads. So possibly due to atrophy out there. But at least the clinical phenotype, what I've mentioned in the yellow, is kind of matching our child. This is VUS, or is it pathogenic, or?
No, I think the clinical side is non-specific for any developmental epileptic encephalopathy.
Yeah.
I think.
This was VUS, sir.
Okay.
Mitochondrial genetics is not done.
So again, as per the last case, I think maybe we have a complete set of images first. We can do a spectroscopy if required, then evaluate for the common disorders presented with basal ganglia changes.
Sure, sir.
You'll see if any other suggestions are there. Ammonia is high, right? I think 393 was high.
It was high, but sir, like it was done outside. We like whether it is processed properly or not, we don't know.
And no skin lesions for any interferonopathy type disorder, right?
No skin lesions, sir.
Okay. Trial given vigabatrin?
He was given, sir, as he presented at around 9 months of age. He was started on vigabatrin also. He was seizure free for almost 2 years. Again, at around 4 years of age, again he had developed again recurrence of the seizures. And there is microcephaly.
Okay, yeah. Meddale possible hearing, yeah, but we don't have the complete set. But child did not have hearing loss, no? No hearing loss or?
No, sir, no hearing loss or no vision impairment.
Dr. Krishnapriya mentions parampenel was given and responded. Any trial of that? Or?
This gene actually affects this AMPA transmembrane receptors according to literature itself. So this parampenel will work. This child is responding to the present anti-seizure medication. So if there is any increase in frequency, so we are planning to start as our backup.
Okay, so given that the imaging was done in 2020.
Yes, it was done 4 years
ago. Again, maybe we can get a rescan possible.
Yes, sir.
Or if the parental, I'm sure parental testing has been done or has been sent.
No, sir, parental testing was not done.
Okay. I think maybe the next step will be if we can get a present scan, in complete
Yes.
set of scan, and then based on that we can take it forward. The literature is very less for the gene, so I'm not sure if we can completely rule that out. But imaging literature.
Sure.
But the common things being common, these are the common ones, and the gene doesn't fit into that. Okay.
So we'll get repeat MRI brain with
Yeah.
MRIs.
Yeah. All right. Okay, go to that.
This is another child, 4 years old girl, with developmental delay, both cognition and language, but motor development is as per age. Like child is hyperactive with poor eye contact and poor sitting tolerance, and she does not reach for objects even now. But hearing is normal. She responds to sounds. She is born out of third-degree consanguineous marriage with assisted vaginal delivery, forceps assisted normal vaginal delivery, full term. Cried immediately after birth, 2.75 kgs. Child had forceps injury with subgaleal bleed at the time of birth, and child had NICU admission in view of TTNB and the requirement of oxygen, but discharged after 2 days. And child had right side focal seizures in the form of right upper limb tonic posturing with right eye blinking and right side deviation of head with multiple that were like multiple episodes lasting for more than 2 hours. This was on 23rd day of life. So child was admitted again for almost 13 days in NICU in view of this refractory seizures and Klebsiella sepsis. Uh, so for this child was evaluated because of this seizures
Okay.
and sepsis.
Thinking of perinatal insult, is that the clinical?
Yes, sir. Now,
Okay.
now like at 4 years of age, like child is having this cognitive and language delay with CVI. Uh, so for radiological evaluation, we have done an imaging because child has significant parental issues also.
All right. I have a CT and MR. CT, I think, was done. Show the date. Yeah, few years back, if I'm not mistaken. And on the CT, you can appreciate multiple intracranial calcifications, predominantly in the peripheral regions of the brain, subcortical, cortical regions. Also, yeah. So multiple calcifications, some plastic changes or some encephalomagnetic changes in the temporal lobe out there, more predominantly on the right temporal lobe, as you can see out here in these images and also in these images. Cerebellum is relatively spared in terms of calcification and any signal abnormalities. So yeah, the CT, non-contrast CT demonstrates a significant multiple intracranial calcifications more around the periphery of the cerebral hemispheres and some gliotic and encephalomagnetic changes in the temporal lobes, more on the right side. With that, I think the differentials for the CT, one would think of, especially these peripheral region calcifications are torch infections are high on the list. Also thyroid parathyroid related disorders, but they are usually also present with more deep brain nuclear changes. So yeah, thinking of at least acquired insults causing the calcifications and also given the gliosis and cephalopolysia, that can also tie into that. MRI was done, I think, later. And on the MRI, if you focus on the T2 sequences, you can appreciate the abnormalities of the temporal lobes, more on the right side. No structural abnormalities, at least on the films. There is some volume loss in the superficial parenchyma, but cortical parenchyma. But yeah, there are no additional changes. What we have seen is no malformations, no focal signal changes, no focal lesions, especially deep brain nuclear structures, white matter structures, all chronic changes, especially centered in the temporal lobes. Diffusion wave sequences did not demonstrate any signal changes, and the SWI GRE you can corroborates with the CT findings of multiple intracranial calcifications. With this imaging findings, I think we're at least imaging wise, we're thinking of perinatal acquired injury causing the imaging findings. Whether that ties up with the clinical phenotype or not is open for discussion. Is the child any history of HIV for the child? Was it tested?
No, sir. Cried immediately after birth.
Okay. No, HIV.
Mm.
That's okay. Yeah. Yeah. So we're thinking perinatal acquired infections radiologically and clinically, and if it fits in or not, or any other suggestions.
When child was admitted at around 23 days of life, they have done serology also, sir. Like according to documentation, it was negative. They have documented.
Amina's Aicardi-Gouttières syndrome. Yeah, calcification, I agree, Amina, but the white matter changes were not what we see in Aicardi are not seen. And this gliotic plastic
And
changes.
don't forget the overall clinical context.
Yeah.
With neonatal problems, infection,
Yeah.
seizures.
A very stormy neonatal courses, I agree.
So, sir, should we take it as like acquired cause due to this perinatal infection?
In my mind, this is the most likely option.
Okay, sir.
Question of vessel calcification. I'm unable to say if there's any vessel calcification on these images. Yeah, but I would say that the encephalomagnetic changes and common being common, it looks like a acquiring site.
Just a question, Nihaal.
Yeah.
Yeah, this calcification on the cortex. You see the cortical calcification, right temporal area, sylvian area.
Yeah, can be dystrophic.
That looks dystrophic calcification,
Yeah.
like some injury and then laminar
Yeah.
necrosis for God knows what.
Yeah, and also associated, encephalomagnetic changes that will go with dystrophic calcification.
Yeah.
So yeah, Harika, I think we agree that acquired is more common than the genetic causes.
Okay, sir.
I'm just thinking if HIV needs to be tested on, but as you say, clinically doesn't.
HIV we didn't test, sir. We'll test it.
But HIV gives rise to basal ganglia calcification more, or?
It can also give to subcortical cortical. I mean, the peripheral calcifications also. Okay. All right, Harika, what do you?
This is another child, 17 months old boy, born out of non-consensus marriage, 36 weeks LSES with birth weight of 2.2 kgs, with no perinatal issues. And this, at the time of birth, no issues. And at around 15 days of life, child had seizures, like with different semiology. Like first seizures were like in awake state with deviation of eyes to right side with eye blinking and tonic stiffness of both the upper limb and lower limb with jerky movements involving right lower limb, lasting for up to 1 minute. And then like child was started on anti-seizure medications and child was discharged at around 1 month of age. And there was a recurrence of seizure at around 1.5 month of age with another type of seizure semiology with right focal and sometimes right focal, sometimes left focal motor seizures, sometimes only associated with eye blinking, lasting for only 15 seconds to 1 minute, almost like 3 to 5 episodes per day that persist for almost 3 months of age. And from 3 to 4 months of age, child had like myoclonic jerks, more after waking up in the form of clusters, lasting for up to 1 minute. And from the last 15 days, when they came to us, there is another semiology with eye blinking and sometimes associated with jerking of right or left lower limb, lasting for less than 1 minute with unresponsiveness. Now on examination, head circumference is 45 and AF is still open, admitting tip of the index finger. There is one big Mongolian spot over right flank region and one big hypopigmented patch involving right upper limb and also right lower limb. And on examination, there is left facial weakness on left hemiparesis and sound induced status are also present. So this is like neonatal onset polymorphic epilepsy, and also there is developmental delay, both motor and cognitive delay. So we have worked up. This is the image of the child, one large hyperpigmented macula on right flank region and also hypo on right upper limb and also lower limb.
Along the lines of Blaschko.
And following Blaschko lines.
Okay. So thinking of hypomenosis right over.
Yes, sir.
Okay.
But this hyperpigmented macula is odd thing.
Okay.
all on one side of the body, only on the right side.
Yeah.
And those are involving only right side, right upper limb, right lower limb, and right top of the abdomen.
Okay. So I think the findings also should be on the right side in the brain. Yeah, so T2-axial images, as you can appreciate, there is cortical malformation out there, almost like a hemimegalencephaly, involving the perisylvian regions going up to the frontal lobes. Yeah, so this is the main area of abnormality. If you look superficially, it's going up to the perisylvian region, frontal lobes out there, but mainly it is centered in the perisylvian region on the right side. There's mild prominence of the ipsilateral lateral ventricle. Yeah, and the rest of the brain does not demonstrate any other structural abnormality. Again, you can appreciate on the coronal sequences the extent of the abnormality, a pachygyric type pattern involving the perisylvian region, and also on the SAT sequences. Similarly, at the top panel, you can appreciate the malformation of there. T1 sequences, nothing to add additionally. Again, you can appreciate the abnormality on the right side. Given the neurocutaneous abnormality and the imaging findings, I would think of possibility involving the mTOR pathway. Tuberous sclerosis is the most common, but it can be also seen in other neurocutaneous disorders which affect this pathway. So I think the imaging findings and also the clinical findings tie up with the mTOR related pathway disorder. Hypomelastocytosis can also have this dysplastic hemimegalencephaly or chondritic dysplasias. And clinically, as Harika has already pointed out, along the Blaschko lines, child had hypomelectic patches. So that ties up with hypomelastocytosis, but only thing was the abnormality in the thorax and the abdomen. So imaging wise, I don't think there's any issue, but yeah, clinically it fits into. Okay, Anas mentions, yeah, same Anas, mTOR path-related disorders. Yeah.
We have not done genetics for this child, so should we go for it?
Yeah, please. Yeah, please go. And also maybe targeted therapy. I'm not sure how it ties up what child needs surgery.
As mentioned, this is a post-signotic mutation, very likely. So this is not in the germline. And if you look for trio exome, you will not find it. You would have to go for genetic testing in the skin. But it has no consequence.
Or maybe in the brain when you remove that part.
Like tissue
Yeah,
genetics.
it's basically many of these have mutations, somatic mutations in the brain abnormalities.
So, sir, this skin tissue genetics, would it be helpful?
It's helpful academic-wise, but it doesn't help the patient, I think.
Yes, sir.
So would you be planning a hemispherotomy, right, in this case?
Yes, actually the child is globally delayed. We are not sure whether the hemispherotomy will actually improve the outcome neurologically, but seizure outcome might be better.
Yeah, but then that might sometimes help the cognitive and other things also. Otherwise, you keep on seizing.
Yeah, true. Thank
How
you.
old is the baby?
1 year now.
1.5 years. 17 months, yeah, 1.5 years.
1.5 years.
Okay, then all the comments. Good morning, schools. All right, Harika, what do you?
This is another child. He's 12 years old boy, born out of non-consanguineous marriage. He presented to us with progressive painless loss of vision, bilateral eye, since last 2 years, but there is no worsening or much improvement in vision in last years. Initially, that was progressive, but after that, it was stabilized. And there is defective color vision also. He cannot identify colors of far objects. And he had history of headache that will be relieved by vomiting once in 2 months previously, but now it is not there. Now on examination, extraocular movements are full, pupils are bilateral reacting to light, and bilateral fundus was done, that was suggestive of optic atrophy. And on visual acuity examination, right eye distant vision is 20/50 and left eye is also 20/50. And he has history of repeated eye blinking when he tries to see like far objects. And like motor examination is normal, gait is normal. So because of this like chronic painless loss of vision, starting from 10 years of age, with fundus showing optic atrophy, we have done imaging.
All right, so I've only dedicated orbit images on the MR, and you can appreciate there is a narrowing of the optic canal out there, and prominence of the CSS spaces along the perioptic sheets, resulting also in some tortuosity and some reduction in the volume of the interorbital segments of the optic nerve. As you can see optic atrophy out here. This is a normal optic nerve, somewhat normal optic nerve, but here you can appreciate the optic atrophy and tortuosity of the optic nerves. Secondary to likely optic canal reduction in the optic canal diameter. We don't have an MRI brain, but we have a CT non-contrast brain, and there is some thickening of the calvarium, at least on the frontal and the parietal bones out there. I don't have dedicated the images of the bone window of the optic canal and the axial sequences. And also we have some images of the other parts of the body. And you can appreciate again, there is increased density of the generalized increased density of the bones. You can appreciate out here, at least the femurs out there, the ribs, and also the limbs, the hand joints, and also the bones of both the hands and also the legs. Given that this picture, we are thinking of diffuse conditions causing sclerosing dysplasias, and possibility of osteopetrosis is to be considered as one of the primary differentials, is what we thought of. If there are any other suggestions, we'll be welcome to hear that. Nihaal, you want to add anything? Any findings here which point out?
I mean, yeah, the other close differential will be picked out in the but in that you will see that terminal tuft resorption, which is not seen here. So I would agree that first differential should be osteoarthrosis based on the images which have been provided. You can see that near the knee joint, you can see that limb
Almost
where
at
flash deformity.
yeah.
And you can't see that medullary cavity that is also more commonly seen with osteopetrosis. Yeah.
There is no organometry and cytopenia, but in the milder forms, you may not find that significantly. So we have sent the genetics. Hopefully, we'll get an answer. If it is something which can be treated by bone marrow transplant, that will be considered.
General comment. Osteopetrosis is not an entity. There are many dominant and recessive forms. I think you will proceed to genetic testing and perhaps first consult an expert or a consortium dealing with rare bone disorders.
Yes, so we have sent genetics, sir. As soon as we get that report, we'll update.
You would have to decompress the canal, right?
Yeah, Rajesh. Actually, it's been last 3 years back. We gave them the option. They disappeared, and then they came recently. So he has remained stable both by the vision and the neurology wise. So that's why we have given the option, get the genetics done, and then by that time make up your mind regarding the surgical, and also if there are only certain genes which will respond to bone marrow transplant. So
that I agree. Bone marrow transplant is the second step, but I'm saying for the visual, he might, he's not very bad. No? He's 20/50, I think.
Yeah, 20/50, and he has remained stable in 3 years. 3 years back, we suggested, but they didn't come back because surgery had run away.
Yeah, I know.
All right, yeah, all of you agree that it's a classic case. Thanks.
Has anyone experienced with decompression of the optic canal?
We had one case, which was not a easy, but it was. I mean, we did only one case so far. The remaining usually come after they are blind, so it becomes very difficult to then justify.
Years ago, we had a case with optic canal compression, but in the context of the craniometaphyseal dysplasia. It was a major undertaking, and this child had also compression of other cranial nerves, in particular hearing. So it was a kind of, how can I say, very difficult situation.
Yeah.
All right, on to the next case. Razi, you're there?
Boy, initially presented in September 2024 with history of migraine fever, intermittent onset on and off for 3 weeks with occipital headache. And cough was there for 3 to 4 days, 4 days, and lower limb pains were there associated with finger. On the day of admission, child had 2 episodes of seizures, basically a coupling of eyes, lasting for 5 minutes and interval gap of 1 hour. So, born to third-degree consanguineous parents, second in birth order, term child LOCI, birth weight was 3 kg, minus to admission. So, normal motor development, mild intellectual delay was there. And at admission, child had hypertension with BP recording of 160 by 110. So initially, we thought of acute febrile illness with hypertension with acute symptomatic seizures. Initial workup for hypertension was done, in which CVPs were normal, CRP was mild elevated, ESR was normal. C3 was reduced, and C4 was normal. Ultrasound abdomen with renal Doppler was done, which came out to be normal, and CVP was normal. UPCR showed nephritic range protein 0.34, and ASO was negative, blood cultures were negative. So MRI brain was done at this point.
All right, so I have 2 such of MRI, September and December, and you can appreciate the changes are such of stress or acute hypertensive encephalopathy. Typical vasogenic edematous seen in the subcortical regions of the posterior hemispheres, also involving the superficial frontal lobes and cerebral hemispheres on both sides. And on follow-up, near complete resolution of the edematous changes. Post that, child came back again in May.
Gradually, on follow-up, hypertensive recordings were reduced, and anti-seizure medications were also tapered, and antihypertensives were weaned off. Later, May 2025, he presented with headache and giddiness for 2 to 3 days. And he had the acute onset difficulty in walking with poor left-hand grip, weakness of left upper limb and lower limb was there, associated with division of nerve towards right side. Vitals, BP was 125 by 68 at admission. He had dysarthric speech, comprehension, repetition, and meaning was intact. Left human facial palsy was there, associated with left-sided hemiparesis, which improved within 24 hours of the onset. But tingling sensation persisted in left upper limb. So repeat MRI with MR angio was done for this child.
Okay, so you can appreciate the impact in the on the right side, going up to the coronary data. This focal abnormality on the different sequences. No other changes of acute abnormalities on the TWIs. On the T280 sequences, you can appreciate generalized cortical volume loss of the cerebral and cerebral hemispheres. Angio, I only these images. Let's see on the angio, at least if you look at the bottom panel, there is some irregularity of the vessels of circular phyllis, the proximal segments of the anterior cerebral artery, the left middle cerebral artery. I do not expect the choroidal artery to be visualized on these films, which the impact pertains to. So some irregularity of the vessels of circular phyllis. Anything else standing out, Anish or Kiran?
No, not really. We'll have to do a better vascular imaging.
Yeah.
Yeah, Moyama is definitely a possibility.
Mm-hmm. Yeah.
The first presentation of stroke, child was evaluated for stroke workup was done. The thrombotic workup was negative. Homocysteine was 15. In that case, was 1.4. DQ was normal. And renal Doppler was repeated along with carotid Doppler, which was normal. Second was negative. The thought of like vasculitis or vasculopathy or like Moya was our difference was ANA with ANA titers with ANA profile was sent. Both were negative. And other vasculitic workup was Priyanka and Priyanka were negative. And CCT abdomen with pelvis was also done. Was done. So it came out to be normal. So IV methyl pulse course was given, followed by oral steroids tapering, was given for 8 weeks. Later, child required like antihypertensive medications. On and off, he was having hypertensive recordings as well. So during this time, considering vasculitis, causing stroke, lacunar stroke. Rheumatology consultation was also taken, and child was planned to start on cyclophosphamide. 2 doses were given, and ceftriaxone prophylaxis was started. For which he had a rash, so we had to stop.
Okay, then we have sent for genetics. That's the next slide.
Yeah, genetics was also sent in view of vasculopathy. Came out to be NOS3 mutation. Cadacil variant was there, autosomal dominant, but variant of unknown significance was there. So we went through the criteria for NOS3 and Cadacil. Most of the criteria like age less than 55 years and subcortical stroke-like episode, and later he had mood disorders and he had severe depression as well, and psychiatric suicidal thoughts and tendencies since past 2 weeks recently. And this was autosomal dominant pattern and not fitting into a pattern of microdystrophy. But the thing was, in genetic NOS3 mutation, this cysteine residues usually gain or loss of function of cysteine residues will happen. But in this case, this valine was replaced with methionine was replaced with valine, but not a classical cysteine loss or gain was there in this case. So for this confirmation, parental segregation need to be sent. So we have sent not the parental segregation for Sanger sequencing, that report is available. At least the clinical criteria was meeting, and genetic criteria we need confirmation with parental sequencing. So recent, we had persistent hypertension, new onset suicidal thoughts and radiation past 2 months. And this persistent headache was there, and generalized body pains for the complaints on regular basis. So the new onset worsening on the imaging. So we thought of planning to repeat MRI with vessel 1 because thinking in mind with Moya as well as vasculitis for vasculitis.
All right. Scanned a couple of days back. And you can appreciate the abnormality what we've seen previously out there with the T2 shine through. And on the player sequences, again, there's hyperintensive foci out there. Some punctate abnormalities in the left temporal lobe and parietal lobe, but no other significant findings. No acute abnormalities on the diffusion sequences. Midline SAG, other than the volume loss of the cerebellum, no other significant changes, maybe mild thinning of the corpus callosum. No hemorrhagic foci on the SPINacademics sequences. Vessel wall imaging was done, and there was no significant contrast uptake on vessel wall imaging. So yeah, no progression or no new changes on the repeat scan. And at least the flow wides appear to be, we don't have an angiom, but the flow wides appear to be okay and not reduced in caliber. So Moya also at this point, I think I wouldn't say So main query, Razi?
Yes, sir. Like, is it fitting into pedicel artery vasculopathy? Features of it, because first initial angio we thought like any radial cerebral artery, there was thinning करके we thought, and but yeah, MR angio negative vasculopathy because of all vasculitic panel was negative. So we were thinking in terms of genetic vasculopathy. Based on that, vessel wall imaging and previous imaging, can we come into a differential?
Okay, Ani suggests to do a CT angio.
This was a contrast MRI angio.
Yeah, Dr. Lokesh. There's no uptake of contrast. No wall enhancement.
And also the vessel walls which are thin in previous angio, is it better now?
That we'll have to compare with an angio itself. But at least the flow wise, I mean, I've not put in the terminal ICS, but yeah, they appear to be okay. But I think angio to angio comparison would be more ideal.
So we requested a contrast angio only.
Okay. They did a contrast vessel wall, but angio wasn't a contrast vessel wall.
Okay. So we'll have to request that separately. It doesn't come.
Yeah, that's a separate sequence. No, no, it.
But can you at least say the vessel wall size at least grossly?
They don't appear to be narrowed or look like progressive disorder, but I would have to just again check the entire, scroll the entire sequence. But at least so here the ICs appear to be intact. The flows appear to be intact and not narrowed. But doing an angio will be more ideal.
Yeah, not a moya phenomenon.
No, it doesn't look like a moya. At least
so
on this at this stage.
Something transient when you had the stroke, the vasospasm. The vasospasm we had the previous year so that was transient phenomena caused a stroke and then it has reversed.
Yes. Amina, so was steroids given before the MRI and for how long?
Second presentation, when child presented in May, child received steroids, pulse course, followed by oral steroids, tapering over 8 weeks. Now only low dose steroids are using, and 3 days later, cyclo was diagnosed.
At least over here, the left side appears more irregular, but again, these images I'm not very sure. The ICA and the MCA, there's some irregularity out there. At least on the current stage, I wouldn't say moya on these images. Maybe we'll wait for the parental segregation and take it forward from there.
Sir, is it consistent with notch 3?
No, the notch 3, there were more widespread changes. These are only for focal abnormalities.
Okay.
But again, they are more in the adult age group. I'm not sure of the pediatric if it starts off like this.
What is the cause of
but in hypertension?
Sorry.
Hypertension, the child I think had renal abnormalities. Is that right?
Initially treated as acute infectious glomerulonephritis. But child is persistent to have hypertension still, almost 1 year now, since the insult, requiring 2 antihypertensive. And now new onset psychiatric symptoms, like suicidal thoughts and tendencies.
The genetics, parental segregation.
Yeah.
Not some collagen disease. ANA is negative, I know, but.
Okay, so at this point, at least doesn't fit into Moya, and we'll wait for the parental segregation, the gene to be positive one. Imaging wise, I wouldn't say Notch 3.
We'll get the segregation report.
Yeah, at least not typical for Notch 3 imaging wise, but maybe this might be an early.
Because literature wise, two siblings had around 13 and 14 years as well present over
Yeah, as you mentioned, white matter lesions, diffuse white matter lesions in the temporal lobe. Yeah, these are more characteristic features. Okay, we'll wait for the results.
Can I make a technical comment or a question? There is a background discussion repeatedly. Can people perhaps unmute their microphone unless they are engaged? Thank you.
Thanks again. All right. Over to Nagpur. Ifshika or Apurva there.
Good evening, everyone. So for today's discussion, we have a 16-year-old boy who was premorbidly ill when he presented to us with complaints of high-grade fever with rash for 2 days associated with puffiness around the eyes. The next day, he developed altered sensorium. He was lethargic. He was not responding to commands. And subsequently, he was taken to a hospital from where he was referred to us. In our emergency, he was noted to have a GCS of E1, V1, M4, and for airway securing the airway, he was intubated. His pupils were 2 mm, sluggishly reacting to light. There was no evidence of any papilledema, no neck rigidity, intermittent dystonic posturing were noted. His deep tendon reflexes were brisk, and extensor plantar response was also noted. On general examination, there was periorbital puffiness along with diffuse petechial rash. There was no organomegaly. Ashkar was looked for thoroughly, but no Ashkar was found. The systemic examination was unremarkable. On investigations, we found hemoconcentration with neutrophilic leukocytosis, thrombocytopenia, elevated transaminases, along with hypoalbuminemia. His D-dimer were elevated, and CPK was also elevated. We worked up for dengue NS1 antigen, which was negative. Subsequently, his dengue IgM was also negative. We, after ensuring that there was no, this picture shows periorbital puffiness. We did CSF as well under platelet cover, and CSF did not show any cells, and sugar and protein were, sugar was 90, 90, and the protein was also 95. So imaging findings. Sir.
Okay. With that, coming to imaging, on the imaging on the diffusion sequences, you can appreciate multiple areas of restricted diffusion, focal area of diffusion in the centrum semial vein, predominantly in the centrum semial on both sides. Some regions, the superficial frontal lobe out there, anterior perimeter of white matter on the left side, the right temporal lobe, bilateral temporal lobe, and a punctate area in the right cerebellar hemisphere. So main findings are these findings on the diffusion sequences with some plastogenic edema also surrounding those foci. Some degree of particle volume loss in the cerebral and cerebellar hemispheres. On the SWI sequences, you can appreciate some of those areas that demonstrate areas of punctate areas of blooming, surge of hemorrhagic foci. Again, yeah, predominantly centered in the centrum semial vein. There are also some punctate foci in the cerebellum and the other regions, especially in the left peritracheal region, but the main findings are areas of restricted diffusion in the deep white matter associated with microhemorrhagic findings. Orbits was, I think, screened. I could not appreciate any significant abnormalities in terms of optic nerve edema or enhancement. Spine was evaluated, and on spine also I could not appreciate any focal or long segment abnormalities, and no post-contrast enhancement of the spinal cord or the caudate nerve roots. With that background, I think imaging differentials, the thought of a possibility of infective vasculitis related disorders, the starry sky appearance, which is commonly described in rickettsia, but can also be seen in other conditions, and infective conditions such as chikungunya and also meningococcal can cause these changes. So imaging wise, we thought at least it's an infective vasculitis, maybe small vessel vasculitis causing these changes. I think clinically the thought was possibility of a tropical fever, encephalopathy, and thrombocytopenia, or a secondary CNS vasculitis. Is it right, Apurva?
Yes, sir. These were all clinical differentials.
Sir, could these imaging findings be seen in dengue as well? Because hemoconcentration and whatever routine investigations we have done, dengue was high on our cards, but the serology has come negative.
Possible, but maybe it will go more focal, more extensive changes. And infection vasculitis with the hematological route is, I think, to be considered. The spread is why the hematological route causing these tiny infarcts and hemorrhagic changes.
Thank you, sir.
Yeah. Yeah. Any other thoughts? Yeah. Suggestions? Dr. Vivek says the two-dose scrub by Lisa and chikungunya and leptospirosis to be ruled out. So we are thinking, yeah, infective causing these changes. Bullet also agrees, yeah. Small vessel infective vasculitis with these microhemorrhagic changes. So to evaluate, as Dr. Vivek has mentioned.
Yes, so we have sent workup for scrub and leptospira. It is awaited, and we have started the kid on doxycycline, with which he has become afebrile.
In your experience, what about the prognosis? What is your expectation? Full recovery or?
Because they are patchy involvement, they generally do recover well, sir. Unless the systemic illness is very severe.
Okay, so Apurva will await the further lab investigations and maybe we can discuss it in the next meeting. Okay, thank you. All right, from Nagpur to Delhi, Anish, over to you.
Yeah, can you hear me?
Yeah.
Yeah, so the case came to us last week. 10-month-old female, history is quite short. Second born of a non-consanguineous marriage, normal birth and development was normal. Had a short course of fever, few hours later, followed by multiple episodes of vomiting. Initially treated not in our hospital, outside as a case of gastroenteritis, dehydration was corrected. And on the second day, developed multiple episodes of seizures, followed by obtunded sensorium, at which time an emergency neuroimaging was done, followed by intubation, and then we were called and the patient was transferred to our center. So when the child reached here, she was intubated, sedated. Seizures were controlled with AED. We had information that pupils were unequal when she was being transferred, but at our center, they were equal. Lab profile, the only relevant was mild anemia, borderline. Otherwise, coagulation profile and all other lab workup was normal. So with that, let's go over to the neuroimaging. Yeah, so we essentially have a posterior fossa abnormality. We see there are cerebellar bleeds involving both cerebellar hemispheres with a lot of vasogenic edema. There is ascending transtentorial herniation, aqueduct and the fourth ventricle are compressed, and significant obstructive hydrocephalus. So now when we see something like this, atypical bleeds, unexplained in any age group predominantly, but especially in a child, no comorbidities, non-hypertensive, these are the conditions we consider, of which thrombocytopenia coagulopathy has already been excluded. So the first thing we need to rule out, of course, is vascular abnormality, either CVT or a vascular malformation. So we had informed the primary hospital that was referring to us to get a vascular imaging done, and CCT was done. So so if you see the CCT, there are some abnormal vascular channels in the posterior fossa in the midline, as Nihaal is pointing out, and in the region, in the retrocerebellar region. And if whatever is appreciable on these images, we can see a quite distended torcula in the second image, the top right hand, quite a distended torcula. and the venous sinuses are opacifying well, so there is no evidence of CVT. So if I were to just see the NCCT, I would have said maybe a CVT, especially given the background of vomiting, dehydration, but there seems to be abnormal vessels. So the clinical thinking was this is a vascular malformation. So now how do we proceed with this case? The child definitely needs a CSF diversion because of the rapidly progressive obstructive hydrocephalus. But in a setting like this, if you divert the CSF and there is a vascular malformation which has bled, you lower the intracranial pressure and the vessels expand and there is a risk of causing a rebleed. So we have to first address the etiology. The child came to us at around 7 or 8 in the evening. Just after some rapid blood workup, we took her up that night at around 10:30, and we did an emergency DSA. So yeah. So what we found was quite more ghastly than what we were expecting. I was hoping for some either a single point fistula which could be easily accessed. So this is a left vertebral angiogram. You can see there is nothing going into the basilar artery from the vertebral artery. So all we can see are prominent feeders, especially a large pica, and on that AP view, and all shunting through multi-hole fistulas into posterior and occipital sinus, and thereafter shunting into the torcular. You can see a distended torcular on both images, and thereafter the blood is shunted into both transverse sigmoid sinuses. And if you go to the next images, Nihaal, please.
Yeah.
Yeah, this is the left vertebral angiogram. Over here, you can see some faint opacification of the basilar artery, but again, from the left pica, which is predominantly filling up, the shunting is through the other side. You can see multiple lace-like vessels, again, feeding the site of the fistula. The left pica is again supplying across the midline onto the left side. Sorry, this is the right pica supplying, going across the midline onto the opposite side. So pretty much there is no posterior fossa perfusion that is happening. The entire blood across vertebral arteries is being shunted to the fistula. Now, if we'll go to some urgent vascular imaging, the IC imaging, you can see again across the PCOM, the superior cerebellar arteries are again shunting blood into the torcular. If you see that lateral view here, yeah, on the lateral view, yeah, you can see again the superior cerebellar arteries are shunting blood. Even the IC circulation is being diverted to the fistula. So this is basically a multi-hole large posterior fossa pial arteriovenous fistula with extensive shunting. We did an emergency bedside echo, which did not show significant cardiac overload. So now what to do with this setting? We had access in a 10-month-old, 7-year-old kid. We taking the angios, we had almost crossed our threshold for contrast administration, but we had to reduce the shunt somewhat so that a CSF diversion could be done on an emergent basis. So we decided to embolize the largest feeder. This is a 3D rotational angiography. You can see that largest feeder draining into a prominent venous circulation. Yeah, just before that, anterior to that, yeah. And the artery which is opening into the, yeah. So this is, we have accessed the pica, hooked the, in the intervention phase, we have hooked the dominant feeder, that is the left pica. Next image, please. And we, you can see this is a microcatheter in the pica, close to the site of fistula. This is a microcatheter angiogram showing the shunt across into the venous side. So we said we'll at least block this feeder, and the child was crashing. Actually, for some reason, the BP was dropping. The anesthetist was screaming at me, we need to stop, we need to stop. Child is already going on tropes. So what we did was we blocked the feeder with coils and a plug of glue. And if you see the next angiogram, the next shoot, please. Next slide. Next slide, please.
Oh, is it not showing?
Am I audible?
Yeah. Is the screen not visible? I mean, I can see the next slide.
Yeah, now it's visible. Yeah. So now you can see this is again the left vertebral artery angiogram. You can see the shunt has significantly reduced, as in although it still looks quite ghastly. At least now we are seeing the basilar artery opacified well. We are seeing the superior cerebellar arteries opacified, whereas previously from the left vert angiogram, we were only seeing the fistula opacified. Only the pica and the fistula. We can see some at least around 30% or something shunt reduction we've had. By this time, we had already crossed our expected doses of contrast. Child was not very stable, so we stopped. And immediately after the procedure, the surgeons went and put in an EVD. And subsequently, 2 days after that, child was holding steady, was converted into a BP shunt. So there were no further episodes of seizures, was managed by a pediatric intensivist, and on day 5, gradually weaned off and extubated. And on extubation, we were pleasantly surprised that all 4 limbs were moving equally. There was evidence of bulbar dysfunction in the form of poor swallowing. It took another 2 to 3 days before the child started accepting oral feeds. So with that, we did an MRI today. And yeah, so I was fearing the worst, that there would be some damage to the brainstem because of the compression. There would be some brainstem edema or infarcts, but thankfully, all we see are the features of the old bleed in the cerebellar hemispheres. The aqueduct is compressed, but there are no brainstem edematous changes, no ischemia in the brainstem. Can we run the videos? Yeah. So there we still see some prominent flow-wards. Of course, the fistula is still there. You can see the prominent topula and the venous sinuses. And in the supratentorial brain, the surgeons have taken care of it. The shunt is working well. If at all slightly working a bit too well, there is a thin film of SDH on the right side, but that's acceptable. So the ventricles are decompressed, the supratentorial brain is preserved. This is the T2 coronal, again showing prominent flow-wards of the sinuses where the fistula is draining. You can see the prominent draining vein posteriorly. The hemorrhage in the cerebellar hemispheres. Yeah, so now the plan is the child is holding steady. We plan is accepting feeds. The rise tube, the NG tube is out. So we are now planning to discharge the child. Child is afebrile, and we've counseled the patients. Complete embolization, complete angiographic cure of such a condition is quite difficult. So we plan staged embolization over multiple sittings. We'll call the child back after 2 to 3 weeks, see the general condition assessed, and based on the consent of the parents, we'll do an angiogram. We cannot, because of our limitations of contrast and procedure time, we can only embolize 1 feeder at a time. So ideally, if these children are stable, we try to tide them over beyond 1 year of age. Of course, not in the setting of vein of Galen malformation, so that the vessels are slightly larger and our hardware can go in more easily. But when push comes to shove, there's no option. We have to do it with the thinnest possible material that we have. So yeah, so just Nihaal, you want to take this one?
Yeah, thanks, Anish. Dr. Vivek has a question. If there's no DSA available at the vicinity, can we do a CT angiovenogram as an alternate to confirm the etiology?
Yeah, I think in such a small child, you will not get a good. So the center that referred to us tried to do their best, but we will not get a definitive answer to the diagnosis. So if you do not have a DSA, you have to somehow arrange for a DSA to be done or transfer the child to a center where a DSA is available. Because in this setting, without a DSA, you do not have a diagnosis, and without a diagnosis, we expected a child to require a posterior fossa decomp based on the decompression based on the amount of mass effect in the posterior fossa. But and if you did this without the DSA, surgeons tried to do a posterior fossa decompression, you would have injured a vessel or two, and then that would have been catastrophic, fatal on table. So you have to have a vascular roadmap, and in such a setting, a DSA is the only option. So that's what I feel. Of course, I'm an interventionist.
Yeah, thanks, Anish. Any other comments or questions? All right. Yeah. So thanks, Anish. I'll just skip the discussion part in want of time, but I just wanted to highlight that case. I think we had discussed this a couple of days back, and thanks to Anish's intervention, I think child has minimal complications or post intervention changes. So that's pretty good.
Yeah, but long way to go.
Yeah, long way to go.
Yeah, and it can re-rupture anytime. So yeah, the problem in such cases is now you have a bleed which is causing a raised ICP. You need to decompress. But if you do not address the fistula, the Monro-Kelly doctrine says that the moment you reduce the intracranial pressure, the vascular compartment increases and there's a risk of rupture. So it's a real, you have to reduce the pressure by a shunt or EVD. And at that stage, the moment you reduce it, just shared a couple of other cases which we've done. Pile arteriovenous fistula. This is an AC anterior circulation. Most of them are single point fistulas and are easy to tackle as in these cases, but this is unfortunately a bad case. Again, if you go to the angiographic images of this case, This was just an MCA at the M1, M2 junction. There was a single point fistula. So these are quite easy to treat, relatively easy to treat. You put coils, you put a plug of glue, and the fistula gets closed completely. Yeah, so that's it from my side. Any questions?
Thank you, Anish. Yeah, any questions? Just wanted to highlight the role of the interventionist in saving the shield and appropriate imaging for this child, time-sensitive imaging and intervention. Sridhar says, yeah, great intervention. Patient is, yeah.
Wonderful work.
All right, with that, we'll go on to another vascular case. Yeah. Anish, you might need your opinions for this case. So, Uti, over to you.
Yes, sir. So this is a 8-year-old male child with normal birth and development history. Came with complaints of recurrent right-sided hemiparesis. There was first episode in November 2024 after a trivial fall when he developed weakness of right upper limb, and he recovered over a few weeks, but they did not seek any treatment for the same. Second episode was in July 2025, the present episode, when he developed same side lower limb weakness. There is no history of any seizures or EPC in the patient. On examination, patient was vitally stable. His head circumference was 52 centimeter, which was normal. Normal anthropometric parameters. Head to toe examination was normal. No neurocutaneous marker. High mental functions were normal. Cranial nerves were normal. In motor examination, he had right-sided upper limb and lower limb spasticity, and power was 4/5. Distal more weak than proximal, and DTRs were exaggerated, and right-sided plantar was extensor. Sensory and cerebellar signs were not there. So after the patient came to us, we investigated the patient. Hemogram was normal. ESR was 5, which was normal. Sickling test was negative. Homocysteine was normal. PTNR, APTT was normal, and ANA immunofluorescence and blood were negative. 2D echo and renal Doppler was normal. Fundus was normal, and we were not able to do anchor profile because of affordability issue.
So I have a few sets of images. I have only angios of the first scan. Don't have parenchymal findings. Again, the images are not optimal. The left IC appears to be abnormal. Is that right?
Yes, sir.
Okay. I'm not able to visualize the left IC, but other. Is that the only finding they mentioned? The images slightly.
So they have reported hypoplastic A1 segment in left ACA and hypoplastic M1 segment in left MCA with paucity of caliber in the MCA cortical branches, and supraclinoid left ICA was also narrowed with multiple collaterals.
Okay, all right. But we don't have brain images, no?
Parenchymal images were not there, but they have reported bilateral periventricular and frontoparietal subcortical white matter hyperintensities without any diffusion restriction.
Okay, fine. We'll have a look at the subsequent images. So this is again follow-up after November and July 2025. At least now we have some parenchymal images. We can appreciate the chronic changes as mentioned. Maybe the axles will be better. Yeah, so the flare sequences, we can appreciate there's cortical volume loss on the left hemisphere. Some areas of gliosis in the periventricular regions extending up to the subcortical white matter and the anterior and posterior regions out there. Also in the right periventricular, posterior periventricular region, there's some gliotic foci out there. Yeah, on these images, yes, maybe basic ganglia has some patchy hyperintensities, possibly some patchy gliotic changes out there. No acute abnormalities in terms of, or no restricted diffusion on the diffusion ADC sequences. And now we have a repeat angio. Again, as mentioned by Richie, they are collaterals and there is narrowing of the ICS. The left ICA is not visualized as again narrowing of the terminal portion of the right ICA. So yeah, fitting into a Moya type presentation. Neck vessels do not demonstrate, I think, any significant abnormalities. And then I think I have a video of cerebral DSA and abdominal aortogram. Let's see if we have. Anish, you want to run by the. So right is again you can appreciate the narrowing out there of the ICA, the terminal portion of the ICA. Okay, so same findings as what we've seen on the angio, narrowing of the terminal ICS with left ICS not clearly visualized or opacified. I think the mention was I mentioned occlusion of the left supraclavian artery with reformation of the distal supraclavian ICS. So high-grade stenosis of the right supraclavian artery distal to the ophthalmic artery origin. Diagnosis, we're thinking of Moya-like phenotype. Child was an aspirin and followed up for 6 weeks. Main queries here.
So we wanted to ask, can it be because of any autoimmune pathology, and we should we consider long-term steroids, or is it some atypical moya, and what is the role of surgical intervention at this stage?
Sheila says to do ANA profile, UP-UC ratio.
Yeah, with this unilateral onset, you have to rule out autoimmune etiology. We have seen one patient with membranous nephropathy presenting with a moya-like picture, but of course, that child had a renal symptoms first and then had a stroke, and that's when we were consulted. But that child also had a unilateral stenosis in the first thing, and then it became bilateral. So any moya, it's a dictum. You have to rule out the acquired secondary moya, and then only you can label it as idiopathic moya. Once it is idiopathic, then your surgical interventions and all those things would help. But you have to rule out all the other causes of acquired moya. So I think ANA panel, UPUC ratio, urine analysis, and all those things would help, if not.
Yes.
But steroids you cannot give before that any positivity in those panels.
So patient has already received 5 days of pulse MPS outside. We have not continued steroids as of now.
Yeah, that's the optimal management. You can do other workup and then see and proceed.
Either Dr. Akas, UP-UC ratio. Can if you just tell us that on just briefly about that.
So I told because it one child what we saw was a child of membranous nephropathy who presented with moya vasculopathy. So that's why I asked UPUs urine protein create ratio for ruling out proteinuria. So maybe some nephrotic range proteinuria might be there, and the child may be one of those vasculitic syndromes.
Please forgive if I make a semantic comment. Moya is taken from the Japanese language and literally translated means puff of smoke. It's written in one word without hyphen and does not need a capital. It's like a tubulinopathy. It's just a technical term.
Yeah.
It was not written by Mr. Moya and Mrs. Moya. So it's just a Japanese term.
Well, thanks, Arvind. Okay, so yeah, you have to, I think, do workup as suggested and then only evaluate further.
Yes, sir. Thank you.
Any other comments? That's the last case. So any other comments or questions?
Just to thank you again for this very good presentation.
Thanks again. All right. There are no further comments. So we'll meet again in 2 weeks' time. Kindly send in your cases by 2nd of September or 3rd by latest, so that we can prepare accordingly. Till next time, have a good night. Bye-bye.